I'm tired this morning. I don't know what it is. I'll make it through it. I always do. Not for job fair. You don't get any sympathy in this room if you ever walk in here as a straight. I'm just tired. Act like y'all aren't. But hey, we can both be tired. I woke up about the time that I started walking up the stairs and somebody said good morning to me, and I woke up. I'm here. I'm already here. I was driving my wife's car in. It's like flying to Germany with two 6'5" football players sitting on each side. How do you drive this thing? Maybe driving it for a few months. And I'm like, oh my goodness. It's a Ford Mustang. You just, no. Then you're like, you're on the ground. Why do you see down into anybody's car to see what they're doing? I don't get it now. It's like, anyway. But it's driving and it got me here, so that's all that matters, right? It's fast. But I'm about to sell my, I can't believe I'm saying this out loud. I'm going to sell my 99 Tahoe at A&P. Love that truck, but it's time to go. If you're looking for a 99 two-door Tahoe that's had everything rebuilt in it, it's going to be for sale. Actually, I wouldn't sell it to anybody else. Not until you're ready. I like to sell cars to people I know anyway, because if you roll out and the wheel falls off, I guarantee you, I didn't know about that. But then there was a friend. See, I just worked that into calling y'all all friends. Even the ones who don't really like me, that's fine. Hey, that's life. Can't like everybody. Well, we're supposed to start Integumentary. I know it's been a few days, and I shouldn't even bring it up. We had our test last week. Two things, and it went well. Two things on there is there was a question, and remember you have to read questions to be specific for the question. Read the words closely, and I'm talking about the one that was it's like 70%. I think it was the lowest miss on the test. So we weren't any real high miss questions, but that one 70-something%, and it's what does the lipid bilayer portion of the plasma membrane consist of? The lipid bilayer is just phospholipids, all lipids, cholesterol, glycolipids, phospholipids. The proteins are associated. They get put in and out of the membrane. So if you say, what does the plasma membrane consist of, that would include proteins. But if you're just looking at that lipid bilayer, right, you're only talking about lipids. That was, I'm going to help you later to think that way. I wasn't trying to get you on that. The other thing was, and I'm going to clear it up, and I'll just tell you straight off the bat, for some reason on mine, I've already said I'm going to give you pan credit on this question, though there's no technical way to say this is right. It was the very first question in the test, and there was enough people who asked about it, which had never happened. This question is normally 100%. So I'm not putting you down, I'm just saying we had a miscommunication. When I see a big miscommunication, I try to write it some way. My way to do that is with pan credit. The answer may not technically be correct. When you're in an anatomical position, if you look at your thumb and your pinky, there's absolutely no technical way, and I have to go into some OT stuff, is saying that your pinky is distal to your thumb, right? It just doesn't work in anatomy. I know technically we're looking at it going, well, mine, I guess maybe somebody had to look at it. But that's no different than trying to say, like, if I normally ask things like, radius and the humerus. So the radius is definitely distal to the humerus. And a lot of times people will say, well, the humerus is superior to the radius, but it's not. Is it, when we're walking the street talking to each other, is it? Sure. But not in anatomy and medicine. You would never say that your radius is inferior to your humerus. It's learning terminology and how we use it. And what people are looking for, if you want an example, is like dermatology. We get real specific when we write down a consult to dermatology, because a lot of times where that lesion isn't going to be there. It may still be there, but it's not going to be as present or as changed. And so we're giving them exact locations. And that's why the key is to know our location. Same thing when you get into derm, they give you all these different examples. What's a vesicle, a bullae, a blister? I still don't have them all out. I have to look it up every time. What are they going to call this? Anyway, the other thing is, somebody asked me, well, how do you talk to you about a question? After the test is not always a great time when people are still testing, but anytime you leave and go, I really do not understand why my answer wasn't correct, or why I missed that question, or where I missed that info, anytime, just let me know. We'll go pull it up on the computer. That's now, that's the next day, whenever we got time. It could be a month from now if you're still thinking about that question. Best time is within 3 days. Because I get 3 days to finalize the test, and I normally don't do it until the 3rd day. That way, if every now and then, it doesn't happen very often anymore, somebody walks in and explains something to me, the way they were thinking, and then I think back to the way I was discussing it. Because sometimes I may say something that throws you off, and I can figure that out. Maybe I'm forgiving on that, and I give that answer also. Not always, but it has happened. Depends on the class. Everybody thinks about things differently. So in fairness, anytime you want to see a question, or you just want to see your exam, I don't care if you made 100. If you want to see it, come over there, we'll pull it up. Alright? But let me know you're coming so I can be there. Or if we have to, we pull it up on Canvas while we're both at home, either way. Alright, any other things before we get into block 2? I know it's not on the top of your minds because it's so far off, and I won't be here for that exam. I got to go learn how to teach for a week. TradeOff came and took over and said everybody has to go back through some type of research course or something to learn the experimental learning model. I guess they're experimenting with teaching us. I don't know. Either way, we'll see. If I don't pass, maybe I won't be here a couple weeks from now. I don't remember when it is. I gotta be in there a whole week like y'all. 8 to 5 or something. I'm like, are you kidding? You want me to sit in a classroom all day? No. It should be fun. I won't be the worst one. Here we go. Integumentary system. Now we're going to break down tissues in detail. I mean, we're going to get deep into muscle tissue, deep into nervous tissue in regards to what's happening down at the cellular level for each one, and where these tissues come from, what's their importance, how they're made up, consistencies. And so the first one we get to is integumentary, and we're just talking about your cutaneous membrane, your covering, and what that consists of. So there's a lot of kind of different nomenclature. If we talk about makeup of the integumentary system, that encompasses a whole range of your skin, your epithelial layer, plus all the associated structures. So hair and nails actually are made of keratinocytes, just like your skin. So they fall under as an accessory structure. We generally have hair on our epithelial tissues also, so it all goes together. Glands, muscles, nerves. We'll see that greatly when we look through the layers of the cutaneous membrane. We use skin a lot. If somebody walks into your clinic, you can see, we talk about cyanosis. First time I ever really saw cyanosis, I was shocked. Because those of you that are medical before, and then you're like me, as a PA, I was out there, I've been a medic for a while, physical therapy. I thought I understood the whole concept. If somebody comes in and they're yellow, they say they're yellow eyes, and you're looking at somebody's eyes and they're just a tinge yellow, I can tell you now that's not cyanosis, probably. But that's the way I always thought of it. It could just be they finished Mr. Wright's test on Friday and you're evaluating them Saturday morning. So their eyes are yellow from drinking, right? Now a guy came in and rolled into my clinic in spinal cord, and I mean, he was, I don't know, close to the color of his heart. I mean, his whole body was glowing. Skin, everything. I was like, how did you make it to my office without somebody stopping you and sending you to the ER? My goodness. But I'd never seen anybody. I said cyanosis. Jaundice. I'm talking about jaundice. Y'all knew that and you were just letting me go? Appreciate it. We know cyanosis because we're military. Everybody knows that. We know it's discoloring. Heart failure. Hey, rashes. We can see rashes. We'll get past this slide. Rashes, anything that tells us what's going on with the patient that we can see, and of course blisters and things. So breaking down these different layers, we got to go through from superficial to deep, what we find in there, what are the structures, and then we'll look at, well, what if we damage them? Like, how's it going to heal itself? So when we look at the skin as a whole, it's considered an organ, largest organ in the body. And the skin consists of a dermis and an epidermis. So from here to here is the dermis, and then from here to here is the epidermis. Down here where you see the fat and blood vessels, major blood vessels, is the hypodermis, or what's called the subcutaneous, below the cutaneous layer. So it's subcutaneous or hypodermis, saying also it's below the dermis. Right? That's not part of the skin. The skin only consists of your dermis and epidermis. We look at all the functions and we get this really busy slide, and most of this we realize already. Right? Thermoregulation, we sweat to cool ourselves off. Right? The hairs on your body actually are there to help retain heat. Right? So you don't have heat loss. Everybody knows that once they shave their head. I mean, when they first do, right? If you've had it for a while, you don't really notice it, but if you go and shave your head, you'll notice how cool that feels to begin with. I see them all. They're pointing all y'all out. I'm not trying to. I was just rolling with it. But, it's in style nowadays. It protects you from the external environment. We get that from abrasions, heat, from Major Holzberg. I got to change up 3 years. I've said Mr. Murray, and everybody knew what I meant. Now you may not. You got to protect you from Major Holzberg and her microbes, right? All those different things. And then you have to. Nobody uses this with me, I'm starting to think. I'm going to keep going. I'm not going to get off track. Excretion of sweat, urea, things that leave the body. Synthesis of vitamin D is a big one. The more sunlight you get, the more vitamin D you're going to be able to make, right? Because that's going to activate vitamin D, or activate the process for vitamin D. We're going to look at that. And then absorb substances. So we really know all of those. Now, there are cell types for the epidermis. If you're just looking at the epidermis, most of those cells are going to be keratinocytes, but we also have melanocytes, right? Langerhans cells, which are a type of macrophage, and then we have these Merkel cells. So we got to look at each one, but like I said, keratinocytes are what we're mostly going to find in the epidermis. So keratinocytes are continuously reproduced. We have a base layer or a basal layer that goes through mitosis constantly. Your skin is constantly shedding, right? And so new cells are being formed and pushed up to the apical surface constantly. Right? As they move up, we're going to see here in a minute that they become full of keratin, and that kills off the nucleus in that cell, and they're going to be associated with some other granules, right? Granular granules that help to waterproof that area. So all of that's there to help protect you. When you look at melanocytes, we got to spend a little bit more time on them because they're important. We're seeing more and more studies, because I've been reading things about melanocytes, what they're finding. I read an interesting thing the other day that y'all may have seen it on the news, because anything that hits major headlines, and it was maybe not because you're in PA school. They took like red dye and some other type of dye, so all these dyes that are found in like Doritos or something, and they were applying them to mice. You ever wonder how they come up with these studies? Like, let's take dye and apply, anyway. And they put the dye on there, and it makes the mice skin translucent. You could like see the organs right through their skin. Oh, that's pretty awesome. If you think of the ramifications, so they were talking about like with different hard IV sticks and stuff, if you could see that vessel through there, would it work between this stuff? That's pretty interesting, I think. But we're talking back to melanocytes, because melanocytes contribute to our skin color. It's one of the three things that help to determine our skin color. But the purpose of melanin is right here, UV light. So the more UV light you're exposed to, the more melanin you're going to make. And that's going to give you a darker or tanned appearance. Doesn't matter what skin color you started out with, they'll become more active. Right? So melanocytes are extending between keratinocytes. And what they're doing is they have these melanin granules that were made. The melanin granules will cluster over the nucleus. But if I draw these a little longer, just let it go. Just let it go. My daughter does that. I don't slow my sneeze down at all. I can cover the whole room. You're gonna blow your nose out. kidding. I don't know who that was, so I was just kidding. But it basically projects around the keratinocytes and transfers the melanin granules to the keratinocytes. The purpose is not for you to become darker or more tan. The purpose is to protect you. Actually, this is another thing we've heard. I'm getting too clinical, but we've heard a lot about this lately, right? Because there's an argument with people saying, should we use sunscreen? That sunscreen's harder on us than the actual protection. Because what the body protects itself by is getting melanin, making melanin granules, transferring them over, and those melanin granules will cluster over. So if here's a nucleus in my skin cell, they're going to get over the top of it and block the UV rays coming into those skin cells. Right? But like everything, I'm sure those studies go into, there's a fine line because you get out in the sun, like I'm out in the sun a while, but I don't get burned normally. But if you get burnt, you're definitely damaging things there. So it's natural protection for you. I haven't read a lot of that, but I know it's out there about don't use sunscreen. I don't know. We didn't use sunscreen when I was growing up. We didn't have any. You know what your sunscreen was? What do you do for the people older in the room? What's the first thing you got to do at the beginning of summer? Burn. Once you get your base layer, and then you won't have to worry about it. Next thing you know, people were slathering cooking oil on themselves, laying out the sun. That's a true story. It really happened. Okay. Now here's another thing. We got to do a little biochemistry here. A melanosome is an organelle of a melanocyte. Okay, so now we didn't talk about that when we looked at the general cell, did we? Remember, some cells have subcellular structures that are different than others. So in a melanocyte, which is a cell, there is an organelle called a melanosome. And the melanosome is what's going to be activated because they have the ability to synthesize melanin from the amino acid tyrosine in the presence of tyrosinase. So break that down. There's melanin, but in order to make melanin, you must have the enzyme in your body, tyrosinase, ACE, meaning enzyme, right? To take amino acid tyrosine and change it into that melanin. So those are key things that we have to have, because if you have a lack, we're going to look at disorders. If you have a lack of tyrosinase, basically that's what albinism is. You have no ability to make melanin. You don't have the same skin color because of that. And we find melanin everywhere. So, but right now we're just discussing the cells. Langerhans cells are macrophages. They're immune cells. So when you look at a Langerhans cell, it's a macrophage that resides in epithelial tissues, and its job is to process antigens and show them to other immune cells. So while Langerhans cells are a macrophage, in that same line of white blood cell, the macrophage, when you're talking about them in Major Holzberg's class, she'll present them, if she hasn't already, as, well, this is a dendritic cell. And it is. But it's still a macrophage. It's a macrophage, though, that mainly functions by presenting antigen. It's already there. Remember, the other macrophages that are coming to there. And so this dendritic cell, Langerhans cell, presents antigens to the immune system. Like I said, it's still a macrophage, but Murray never called it that. Even I went and questioned him once about it. He said, yeah, same thing. He said, I got tired of explaining that it was a macrophage and a dendritic cell. And I said, well, I explained in about 30 seconds, and I just move on. I guess he used to get a lot of questions, so they get a little deeper into it. Hey, Merkel cells, the last skin cell type. These are going to be found down in the bottom of the epidermis, almost right before you get to the dermis. So it's deep in the epidermis. And this is a Merkel cell. That's the cell. But you have sensory neurons that come from your central nervous system out to that area. The purpose of a sensory neuron is to take the sensory and bring it back to the central nervous system. So this is a sensory neuron. You just can't see the rest of it. And it has this area here that's called a tactile disc, or a Merkel disc in this case. And so this cell sits on that tactile disc. and it helps with the function of touch, right? Actually, and pressure kind of things, but because there's a difference we'll see between light touch, what sensory picks up light touch, what sensory picks up deep touch, and how the body distinguishes between them. But part of it's Merkel cells. Okay, so looking at the layer. As a joke when I was a kid, your mom, dad, y'all probably still do it, people would say, hey, come on kids, hey, you got your epidermis. And they don't know what that is, of course. And everybody calls your outer layer your skin, your epidermis, which is true. But now that we're looking at the layers, I've changed it up to say everybody looks corny. Right? Because your outer layer, the most superficial layer of your epidermis is called your stratum corneum. So now you're corny. Underneath that, you'll have mainly 4 layers, but there's 5 in some other areas. So you have stratum lucidum, stratum granulosum, stratum spinosum, and then the base. The base is where that mitosis is mainly going on. Right? So you have the mnemonic there, come, let's get some beer, however you want to use that. Just if you're talking about the base, we know we're deeper. If you're talking about the corneum, everybody's corny, we're superficial. We can see that. So we can see the superficial layer of cornea, but we can't see the base layer in people. That'll help keep you straight which way you're going. And then we'll talk about each one of these does its own thing. But the concept here is we're going to move up from the basal layer up to the apical layer, or what's called stratum corneum. So the stratum basal, we're going to do them backwards. We're going to go deep to superficial. That's the way they move. And so the layer that we see down here is our base layer. Almost all of those are keratinocytes. And this is where we go back to. Remember when we had microfilaments and intermediate filaments? In these keratinocytes, the intermediate filaments actually change. They're called tonofilaments instead of intermediate filaments. And tonofilaments are a protein that becomes keratin. So that part of what we call a cytoskeleton, the intermediate filaments in skin keratinocytes are called tonofilaments, and tonofilaments become keratin. Okay. And then of course that base layer is constantly undergoing mitosis, so we would not be able to reproduce these skin cells. The next layer up, just superficial to the basal layer, is you have a bunch of layers of keratinocytes. And I said a bunch of layers because I'm not worried if you know exactly how many cells are in that layer. There's a bunch of layers of keratinocytes. Most of these are still alive. Some at the base part may still be finishing dividing if they were to look at it under a microscope. And then as they approach the more superficial layer, let's say of the spinosum, they start to flatten. They're not dead yet, but they start to flatten. The next layer up is granulosum, and this is where they're really flattened out. This is your stratum granulosum. This is the layer, by definition, where we take those deeper living cells, and once they leave this layer, they generally have died off. Right? So at this point in that stratum granulosum is where we start to fill with keratin. When that cell fills with keratin, right, you have a keratinocyte and it has a nucleus. Right? Once it fills with keratin, that nucleus is going to die. Right? So you see the little dots in there. That's the nucleus, but as you get to the top of this layer, those nucleus will disappear. So that cell is dead and now filled with keratin, and it also, in this area, they start to release glomerular granules, which kind of go in between these cells and help to waterproof your skin to an extent. Our skin's not fully waterproof, so it's a lipid that gets between your skin cells. That's what glomerular granules are. And then the stratum lucidum. I said there are 4 layers in most areas. Anywhere that has high friction, you're going to have 5 layers. You're going to include the stratum lucidum, which is a bunch of dead, flat keratinocytes filled with keratin. So this area here is the stratum lucidum. It looks kind of clear, but you only find this like on your fingertips, palms, the soles of your feet, anywhere we think about taking like fingerprints and things. There are areas of high friction, so they have that extra layer. Especially the soles of your feet, you can tell they're much thicker, right? And then the last one, corneum, is where we take those superficial layers. All the cells are dead, they're full of keratin, they're starting to slough off, they have no nucleus, they have glomerular granules between them, and as they slough off, we will continually replace them by moving new cells up and up. So before we even get to disorders, whether it's a burn, infection, a knife cut, anything that damages the epidermis, we'll see later, as long as you're in the epidermis, you should not scar, right? Because you have a basal layer. As long as you're above the basal layer, that should heal just fine. You'll just make new cells. We're going to talk about epidermal wound healing here later in this block, but I like that concept thought because as long as you're above these, and you damage it, it won't scar. Which is interesting also because if you take a sunburn that has blisters, you've affected the dermis. So now you've really done some damage. But we know even those little bubble blisters that you think aren't a big deal, that's officially at least a second-degree sunburn, and you've gone down below your basal layer to cause those blisters. Right, so that's the epidermis, and now deep to that we have the dermis. The dermis is a bunch of irregular connective tissue. It's dense, it's thick, it's full of blood vessels. This is where we're going to find our nerves. We're going to find sebaceous glands and pseudoiferous glands. If you've never heard those, you're going to hear them a lot. A sebaceous gland is an oil gland, and a pseudoiferous gland is a sweat gland. And then we'll have hairs, so that follicles for the hairs that we see on our skin are actually, the follicle itself resides down here in the dermis. And then it'll have this little muscle associated with each hair called the erectoris pilorum muscles. And we can divide this into, if we drew another line, we would say that there is a papillary region, right? And there's a reticular region. So this is the papillary region up here, and this is the reticular region. So I want to make sure I want to show you this. This is papillary region actually is kind of convoluted. That helps to spread out the surface area of how your epithelial cells attach to the underlying dermis. And it also, we'll see on the fingerprint slide, that's what makes your fingerprints. And the papillary region is also what released, or sorry, what makes part of the basement membrane. But it came from there. Okay, so here's our areolar connective adipose tissues. We're down into the sub-Q now. We'll come back to these structures that are up in the skin. We're down below. So all of this area here now is your subcutaneous. You have much larger blood vessels. Right? We have fibers in there that are going to attach the dermis to the deeper tissues. Right? Down to muscle would be like a deeper tissue or fascia. Right? What we're going to find when we get down into the subcutaneous layers, we start to see what's called Pacinian corpuscles that are lamellated. They're often called lamellated corpuscles. They sense pressure. A lamellated corpuscle, we don't get a lot into this till we get to neuro, but when you look at, this is a nerve cell, if you can't tell. Nerve cell that has dendrites and an axon. Right? Sometimes you have free dendrites that pick up things like itch and tickle, and other times when you want it to be more sensitive, like for these pressure, they'll put a connective tissue capsule around the dendrites. That's encapsulated, lamellated, right? And that's what Pacinian corpuscles look like. that, as we'll see later, just increases their sensitivity, basically. I'm getting a little bit ahead, but that's, if you don't, I like to know what words mean when I go through them. It means you put like an onion over your dendrites. It's like a little onion. What is the most superficial layer of the epidermis? Everybody knows that right now. And then we look at our fingerprints. Fingerprints are actually ridges in your epidermis that are made by how the epidermis attaches to the dermis at the papillary region. So all those little squiggly areas or ridges are going to form different fingerprints, and of course they're going to be unique. And nobody has the same fingerprints, palm prints. I love it. I always say when they catch criminals because they were like had no shoes. Who robs a house with no shoes on? I don't get that. They get their footprint and get them. I'm like, that's great. It's good stuff. At the top of these ridges, the lines aren't exactly around here. You're going to have sweat pores. The sweat pores are why you leave fingerprints. Fingerprints are epidermal ridges. All right. Then we get to skin color. Skin color is contributed by three different things. Melanin is a major player. Keratin is also. When you look at hemoglobin, hemoglobin does play a role in skin color, but most of our skin color, you can't see that very well. We can if we pull our lower lip down, right? When we're looking for cyanosis, we're looking for areas that have no pigmentation, basically. There, underneath your arms, different things are more really kind of translucent compared to other areas. When you look at melanin, this another thing I find really interesting in anatomy is when you look at melanin in your cells, that's genetically determined how much melanin you're going to express. Keratin also, genetically determined. So the classic colors of races in the world are genetically determined by how much melanin is being produced and how much keratin. Hemoglobin is just how much oxygen you have in the body, so that's going to vary. So if you look at the amount of melanin, they would say, well, you can go from pale yellow, white as we say, all the way to darker tan, black, however you want to classify that color, but it's a result of melanins. But the only difference with melanin is, this is the interesting part, is no matter whether you're light skin, dark skin, melanin is genetically determined. But you have the same, everyone in here has the same number of melanocytes. Well, unless you have albinism or you're developing vitiligo. What do they call it? Disclaimer? No. But if you have the same number of melanocytes, why do some people have darker skin than others? It's the activity of the melanocytes. So those same melanocytes in a darker skinned individual are more active. And that's determined by genetics. Right? Can you increase the activity in anybody in here of melanocytes? Yes. You can go out in the sun and tan and burn, whatever you want to do. That's going to increase the activity of your melanocytes. Keratin, we said, also plays a color. It's a yellow-orange pigment. It's important because it's a precursor to vitamin A. You know that we say that there's melanin in different parts of the body, keratin in different parts of the body. But when you look at vitamin A, that helps to synthesize pigments that we're going to discuss under special senses for the eyes. Right? So vitamin A is actually good for helping to produce these pigments. And then hemoglobin. Hemoglobin is where we're carrying oxygen in the body. So if you had no melanin and no keratin, no melanin, that's right, and no keratin, you'd have a clear appearance, basically not clear, but lighter or less colored appearance. You'd be able to see the hemoglobin there. If you ever notice any really fair-skinned people, sometimes you can see that, right? And it just makes the skin appear pink because you have oxygen levels. Right. Then to the last part of here, we're looking at epithelial layers. Remember, we said accessory functions. Hair, nails. And so we're going to look at how hair and nails are formed. You probably won't get back to that until you get into derm, but this is kind of an introduction of where they come from. And then glands. Once again, sebaceous glands, pseudoinferiorous glands, oil glands, or sweat glands. You find sebaceous glands other places, but sebaceous glands anywhere you have hair, face, head, arms, you can have sebaceous glands because they're associated with the hair follicle. Right? Can be a problem. Alright, so breaking down hair. Hair is just keratin with proteins with it. Okay. So if you looked at, this is your epidermal layer, and if you looked at what's coming out of it, that's considered to be the shaft. The shaft does extend down into that epidermis dermis, but this whole layer is considered the shaft, and that's what protrudes out. Inside the shaft, you have three different layers: the medulla, the cortex, and the cuticle. So if it's not blown up, hopefully it is on the screen. Here's the medulla. And I can't even see that on the screen, but I know that's correct. I just can't read the words on it. Yeah. So you have the deepest layer, the medulla, the cortex, and then the cuticle. Or cubicle, sorry. Cubicle. Those layers are making up that, but they're coming from down in the root of this hair. Because down in the root, as we're progressing down, what we actually also have is an external root sheath that's here. We have internal root sheath, an external root sheath, and then a dermal root sheath. So all of those layers exist there. The dermal root sheath is an extension of epidermis down into the dermis. Okay, so if we were to look up here and find the hair follicle, this epidermis comes down and surrounds it. That's an epidermal root sheath. And then inside of that we have our external root sheath to the internal root sheath. Right? That's how we look at those layers. When you're looking at composition, once again, just keratin. Keratin plays a lot of different roles in the skins, and you always got to have associated proteins. If we look at the root, we'll say the root's down in the dermis. Now there's some books that you can read and talk about and argue if you like dermatology, saying, well, is the root of the hair considered part of the epidermis or the dermis? Okay, well, Tora is saying it's part of the dermis. Don't write this down. But the epidermal root sheath comes down from the epidermis and goes down into the dermis, right? So people will say, well, that's actually part of the epidermis. Well, don't ever think about it again. I just wanted to mention it. You will see that sometimes, that it's part of it. But for us, the root is in the dermis. Why do we want to look at it that way? Because why do we learn all these things? For damage, disease, disorder. So we want to know, well, if you burn your epidermis completely off, you will not damage your hair root. But if we burn the dermis, we could affect those hair roots, right? That's why I like to think of that way more. So if you look at cell division, as you're finding down towards the bottom, you're going to have the matrix. I thought I had a blow up with this. We're going to produce cells just like we did in other epithelial cells. We're going to have a basal layer down in here that has germinal cells, and we're going to have this kind of hair matrix, right? As the matrix have a basal layer, and as they produce more keratinocytes, they're going to push their way up. The canal that root actually goes through is called the pillary canal, and eventually that hair will start to grow out of the head. So there is a matrix there. When we get to associated structures just with hair cells, you have oil glands, right? Every one of them is going to have an oil gland or sebaceous gland associated with it, and it's also going to have an erector pylorus muscle. Right? That's to keep you safe if you didn't know. It's if you get things like we call goosebumps are your hair standing up, or you get those little bumps, and it's because the erector pylori muscles are contracting and causing your hairs to stand up. And supposedly that comes from an evolutionary advantage that if something, saber-toothed tiger is chasing you, you can turn around, stand all your hairs up, and scare it like a porcupine does. So that's funny. I don't know. I've been waiting to try that, but I don't know if I can pull it off. But now, you make you look larger. If you want to look more buff or larger, start making all your hair stand on end, I guess. Guess it depends on how hairy you are. But. See, I stopped right there. See, I did it. I got to pat myself on the back because I could have just kept going with something silly. Interesting things that they found. My favorite way to see them is all these videos of spouses scaring spouses and posting it on like Instagram. That's just plain mean. There's like people getting hurt. I'm laughing at them still. All right, mine better not do it. Okay, hair root plexus. Surrounding the root, you're going to have nerve fibers that come up and surround the bulb. Right? So as that hair is sitting down here in the bulb, there's the hair shaft, here's the bulb, and then you have nerve fibers that sit around it, kind of wrap around it. And so the hair acts like a fulcrum, so that if a bug's walking through your hair, you can feel that on there. You're going to feel that move. Right? It makes it very sensitive to that hair shaft moving. And we'll get to this later, but as you stimulate these dendrites, basically these nerve cells, that will cause a signal to be sent back to the central nervous system. Tell you what's going on. It doesn't do any good to have a sensory that doesn't talk to the CNS. You would never know. Okay, and then nails. Nails are similar to hair in that each nail, when we look at it, is a bunch of keratinocytes, but you're going to have different areas. This part of the nail is the nail body. And out here, if you have, I always cut all mine off, but if you have white at the end of your nails, right, that's the free edge. And so that whitish area towards the side would be the free edge. And if you look at the back of the body of your nail, you can't see it well in this picture, you can see it better on yourself. If you look at the proximal portion of your fingernail, which that throw out, it has this kind of half moon. That's called your lunula. Right? That's that area. And it's basically just harder cells as they're being pushed up. That's the lunula. If we look for skin color, right, we can check that at the nails because there are a lot of capillaries that are under the nails. So it's an area where we can check for like cyanosis and things on our nails because we can see through there. Because normally it's a pinkish color. And if we go down to the deeper layers, we're going to see that there is a nail root, and surrounding that back here is the nail matrix. That's why you see the nail matrix is where you're making new keratinocytes. And then as they move up through the root, they're going to get packed very hardly, and you're going to start to push the nail as it grows, or as the deeper becomes superficial, they're going to pack very hardly, and your nail will start to grow out. Once again, nails, I never realized this till I came to PA school. Your nails actually tell a lot about what's going on in your body also. You're going to learn in a lot of different disorders, like what's a sign, like they give you a question and somebody in there has like pitting on their nails or streaks on their nails, that kind of thing. Not like ingrown, we know it is. You're going to have different disorders that are associated sometimes with fingernail changes. It's just another sign. It's not definitive, but that can happen. I'm going to leave that for Durham, though, because it's time for us to take a break. Y'all are hanging in there, but we still got a break. Everybody back away. People were asking, so my daughter's doing 100% fine. Thank y'all. Some of y'all that were asking that, the others that didn't. She's
amazingly fine. I did find out that she rolled completely over in 1.5 times. Not just, I thought she just went off the road onto her side. And the guy behind her said, no, when that lady hit her, she flipped and then wound up on the passenger side. So she rolled completely over. I'm like, oh.
It's terrible.
Yeah, I'm like, that's awesome.
How's your credit card recovery?
What's that?
How's the credit card recovery? Yours, yeah.
Mine's not doing well. I'm spending a lot of money lately that I didn't intend to. But I start finagling. That's where all that comes in that I didn't talk. Why would you sell the tile? I love the tile. Well, common sense comes, and I'll get another one. All right, that's that. Next year, maybe I'll be fixing another one up. I like to do that. I like to fix 95 to 99 Tahoes back up. I don't like 4-door. It's got to be a 2-door and then sell it. That's what I do for fun. Other than that, I have 5 kids and all of them drive. 4 of them are still on my payroll. So I've asked my insurance, do I get a fleet discount? And they said, well, you don't want fleet prices on your insurance. I said, good point. But I pay a lot of cars and something's always going wrong because we don't buy new cars.
Do they always drive 95 to 99 Tahoes?
No, they've never driven.
No?
My son drives a 2010 Dodge Cumming piece of junk truck, but I don't like them. I know. I'm not offending the Dodge people. I don't like them. Big, loud, smokes. Suspension's always breaking because they won't stop screwing with it. I'm like, get rid of that thing, man. Get you a nice Chevy. There we go. Yeah. No, it's not getting started. I heard Duramax on yet. Is it Cummins or Duramax? Which is better? No, let's not do it. I think the Cummins is better. I just throw it out there. Even though I'm a Chevy person. I don't drive diesel, so. Okay. A lot of talking to y'all already. We just started this semester. But we got to continue on. Because some people in here are more type A than others, and they're like, can we get to this? Yes, we can. Okay. Sebaceous glands. When you look at sebaceous glands, we're just talking about oil. Excreted out there onto the skin. Its job is to keep your hair from drying out. Right? So when we look at, I box it out there, associated with these hair follicles, you have sebaceous glands, and that oil will move along with the shaft of the hair up out onto the surface there and onto the hair. Okay. So it's preventing excessive water evaporation from the skin. It's actually helping to inhibit some growth of bacteria. And it's also why you're seeing this more nowadays, though people have done it forever, is that washing your hair, I mean, I take a shower every day and wash my hair. Of course, I have very short hair, but washing your hair, especially like longer hair, is not excessively, is not going to be good. In general, you need that oil, and it's like you need earwax. You need that oil on your hair a little bit. So some people have gone where they don't wash their hair every single day because it causes excessive drying of your hair. See people using these dry shampoos and stuff. I only know because it comes out of my wall. But I use like 15 in one. It's like bottle and it works for everything. Everything. I mean, I'm good looking without all that stuff. Well, that was a joke. Y'all just laugh a little bit harder. Now, don't wash your hair too much. Especially if you're one of those people that wash their hair like twice a day, you're really drying the hair out. You're wondering why your hair looks brittle and frizzy. Wait until you get to dermatology. They'll talk a lot about that stuff. Okay, pseudohyperous glands are sweat glands. Now, sweat glands aren't associated with hair follicles, but they, in areas with hair, you see them. And so we have 2 types. You have eccrine sweat glands and apocrine sweat glands. Okay, so here's where we see one of those changes that we don't like in names. An eccrine sweat gland is actually just American sweat gland. American glands, we said, are the most common type. Okay? And in skin, we find those. And then you have these, that's an eccrine sweat gland, and then you have apocrine sweat glands. Now, I want you to learn all these parts of the dermis, epidermis, and where we find these things, but I don't want you to label this. And this picture's in your study pictures. I'm not looking for you to label this, because if this made me think of that, is I label it as in, can you tell the difference between an eccrine and an apocrine sweat gland on this picture? They look 100% the same to me. I know some people worry about that kind of stuff, so I'm telling you that. No. But when we go back to, could you distinguish the epidermal from the dermal layer, that kind of thing? Sure. Is the hair root in the dermis? Yes. You know, where do you find certain structures? That's a good point, but not for labeling, okay? Because this picture is very hard if you get to that. All right. When you look at eccrine sweat glands, you find them everywhere. But you also have apocrine sweat glands. Now it reads funny, found and associated with the hair that develops at puberty. They're already there. The apocrine sweat glands you have, they don't develop at puberty. What it's saying is anywhere secondary sex characteristics where you start to grow hair that you didn't have when you were younger, right? You go through puberty, those areas you tend to find a lot more of these apocrine sweat glands. But they were already there. So they didn't just develop all of a sudden. Alright, skin disorders, because I like skin disorders in brief. You have psoriasis. Psoriasis, the problem is your keratinocytes are being made way too fast. They've gone into hypergear, and as they start to divide more and more quickly, and they push those cells up, well, those cells moving up to those layers are on basically the body's kind of time frame. And if you push them up too quickly, you're going to have immature cells with immature keratin. They haven't completed that process fully, and they're going to get to the outer layers. Right? So they got up to the corneum very quickly, and since they're immature, they look flaky, silvery, and they'll start to build up. They're a little harder to flake off, too. And so they also include things like dandruff, dandruff can be caused by different things, but that process can be there. You can have the dandruff appearance from producing them too quickly, like in psoriasis. And then skin cancer. We get out in the sun. So all skin cancers are associated with excessive UV light exposure. Most. Now we'll see in 10 years if sunscreen, actually now they're studying if sunscreen actually helped cause any of that. I don't know. I'm still using sunscreen though. I just don't like the burn anymore. Hey, the three common types. You have basal cell, squamous cell, and then malignant melanomas. If you live long enough, you'll probably develop basal cell. A lot of people will develop squamous cell carcinomas. It's just a fact of life because we're out in that environment, especially on the head and neck. Least common is melanoma. When you look at normal moles versus abnormal moles, you're going to find in dermatology you study how to recognize like what possibly might be melanomas by is it irregular borders, is it darker in areas, right? Does it change, is it growing, that kind of thing, versus just a normal mole. You'll learn to distinguish between those two so that you can pick out malignant melanoma. So like I said, everybody will probably have basal cell, maybe squamous cell. It'll be fine for most people, right? If you leave squamous cell, if you leave basal cell carcinoma alone, it probably, your odds of it developing into skin cancer, full skin cancer, are a little more rare. But if you do squamous cell carcinomas, you leave them alone, they will start to develop. Depends on the individual. If you got malignant melanoma, it's not something you want to have. Alright, albinism. Going back to melanocytes. Albinism means that you inherited an inability to produce melanin. Melanin's in your hair, your eyes, your skin. All of these areas have melanin in them to help contribute to the color. And so if you don't have the ability to make melanin, you have albinism. Okay? So in albinism, the problem is you do not have this. Your melanocytes have organelles in them called melanosomes. Melanosomes make melanin. That's where we went back. Melanosomes take tyrosinase in the presence of the melanosomes take tyrosine in the presence of tyrosinase, the enzyme, to make melanin. But if you cannot make, or if you don't have the enzyme, you can't make melanin. And that's going to happen at birth. Now, you're not going to develop this later on. The hypodermis is also known as the subcutaneous layer and is part of the skin.
False.
There you go. False. That's why we don't like true false questions, because it very easily can throw you off. You know, that all sounds correct. Yeah, that's not part of the skin. It is the subcutaneous layer, but it's not part of the skin. Okay. What you can develop is vitiligo. We blame a lot of things on Major Holzberg. She doesn't know, like Mr. Murray knows I used to use it a lot. She doesn't know this yet, so I have to tell her I use your name a lot. Anything that's associated with the immune system, I throw micro under the bus. It's their problem. But vitiligo is where you start to lose melanocytes. Right? So you start to have this patchy look or irregular kind of white spots. Happens in all races. This is a disorder where they've seen the immune system's actually attacking the melanocytes in this area. They've seen it run in families, so they'll say there's a genetic link. But you were born, right, with the ability to produce melanin, but in this case, your immune system's going in and deciding, for whatever reason that might be, I'm going to start to kill off melanocytes. Your skin's going to be fine, you just can't produce melanin in that area. Right? And you see different examples. This is pretty common, you see it around. I think they said Michael Jackson had it, possibly vitiligo. I don't know if he did or not. But leave the guy alone. I think it's vitiligo. I don't know. Cyanosis. We all go back to our military training. We've heard of cyanosis. When these mucous membranes looking inside your lip, your nails, actually inside your eyes, right? Anywhere that we can see the blood vessels clear because there's no melon or anything in the way, we can pick up on cyanosis. It's a bluing or purplish look to those areas because you have no oxygen. And hemoglobin that we can see there, remember, it contributes to skin color. Those are areas where we can see how much hemoglobin or how much oxygen the hemoglobin is carrying. So as you start to deplete that, those areas will come purplish. Now I discussed this earlier, even though I was talking about something else, but at the same time I was mentioning jaundice. But jaundice is actually, the problem with that individual being yellow in front of me is that I know that their liver is in full failure by that point. It's getting there. And sure enough, he was a hepatitis C patient, but and he had done that before, I guess. But it was shocking. But there's a yellow pigment. Bilirubin has a yellowish appearance. And so as your liver is not functioning well, you'll start to build up bilirubin in the body, and you'll start to see that present as a yellowish appearance. And yes, it will start with areas like the eyes and stuff first. That's why you kind of look. It won't always be drastic. But that was one case where we rolled in and I wanted to go, that's jaundice. And I wanted to take you around the clinics and show everybody. This is jaundice. Jaundice. Don't ever do that. I'm being funny in here, not in the clinic. Actually, you can't even look shocked when that patient comes in. Right? I joke a lot, but believe it or not, in the clinic, I'm really serious. I don't normally joke unless we're on the plane. Then you can have fun. There's nothing. A patient coming in, even if they're joking, expects you to be serious provider. If you start joking with them like your buddy's on the street, laying down the load when what you were telling them doesn't help like they wanted it to, all of a sudden you're an idiot. You don't know what you're doing, all you do is joke. And you owe it to them, be serious to them. That's right. And that's Run the Flame. And you tell me that of both of y'all, seeing two soldiers, sorry, I digress, seeing two soldiers in Kosovo, they had gone to Greece on R&R, and the medic comes to me and says, hey, there's two, he said kids, but there's two people here, and they both have the same complaint. And I said, what's that? And they said, well, they're worried because they went into, what, Greece, anyway. What's that country? It's run by Russian people, but a bunch of Russian clothes. Anyway, I don't know. They went to an R&R site, where one of those sites where the military goes, y'all go out there and don't drink too much and have fun, and they turn their back and people go crazy and they know they do it, they act like they don't. Bulgaria. This is Bulgaria. Sofia, Bulgaria. Russian mafia runs that place. I gotta shorten this up. So these two guys came in, and I said, what's their complaint? I said, well, they went to something in Bulgaria, and they said that they're worried they have an STD, basically. And I went in one room, I talked to the guy, I went in the other room, I talked to the guy. In the military, you do this, and I got the guy out of the second, I said, come with me. I brought him over to the other guy's room, and I said, like Steve Harvey almost, now that I think about it. So both of y'all are telling me the condom broke. I mean, you're telling me the exact same story. Anyway, that was fun for me. But you're going to treat them the same. Don't do that in the civilian world. That would never, you'll be sued. But I just thought it was funny. I was going to help them, but I'm like, man, I'm like an honest person. Just come in and go, dude, I got crazy in Bulgaria. Can you check me? Yeah, sure. Had plenty of colonels call me over. Can you check me without me coming into the clinic? Sorry, that threw that out. Y'all know that happens. Y'all know that happens. Okay. Erythema. Redness of the skin. Why is it red? It's injured, it's exposed to heat. All this is blood coming to the surface, engorgement of your capillaries. But it can also indicate infection, inflammation, or allergic reaction. Like if somebody has an allergic reaction to nickel. It's one of the most common things, it's not the most common, but it's still pretty common. People come in and they have rash like around their belly button, and they don't know that they're allergic to like nickel, but most belt buckles contain like nickel, cheap jewelry in the ears. My girls all try to tell me they have nickel allergies, so I can only wear gold. Did a good job. Stainless steel. James Avery. Actually, that's no cheaper. Okay, striae. I'm going to stay on track the rest of the time. When you look at striae or streaks, you've actually damaged the dermis. Right? Because anything that affects the epidermis will heal just fine. But if you damage the dermis, you're going to start to see scarring. Well, before the scarring occurs, like if you have excessive weight gain during pregnancy, people growing during puberty too fast, you can start to stretch the dermis, and it's going to show up at these striae, which in a lot of cases, depending on the severity, it can scar down and look whitish as scars for a long time. But a lot of times, especially on growing kids and things, these can remodel, which may be stuck with them. But either way, that's what it's from. You're tearing the dermis, basically. Alopecia is a complete or almost complete lack of hair. There's different types of alopecia. This is like an Alzheimer's baldness comes in and stuff. But if you had chemotherapy, right? If you had skin diseases, a lot of these can cause hair loss. So that's just called alopecia, whether you have full hair loss or not. It's just the name for it. I gave you a bunch of conditions here. Last one is contact dermatitis, and that's for a nickel allergy would be a contact dermatitis. In other words, whatever contacted your skin is irritating to it. Is that poison ivy? Is that the new, latest, greatest beauty product that you put on it? Anything that affects your skin, any type of chemical causes an allergic reaction, that's contact dermatitis. A lot of contact dermatitis you see with people coming in. I got a rash all over my torso. I don't know what it is, and they're not going to believe you when you say, okay, well, what have you changed? And if you really investigate them, you'll find out that they didn't have this rash until they changed like their laundry soap. And it's funny, they don't get it. You have people take off their shirt, and they have a rash, like a t-shirt like they had on. And you're like, you didn't notice it looks just like your shirt. It's coming from your shirt. You don't have cancer. Everybody Googles nowadays and they have cancer, right? Before they come in. But when you start talking to people, let's go through what you do. Oh, it ain't that. They don't want to hear it, including my own family. Alright, wound healing. Some of my favorite stuff I've done in my life, and spinal cord injury is not like you think. Doing constant, if you're a spinal cord injury today, a lot of what I did was inpatient medicine managing all the different conditions, and dealing with wounds. So a large part of my day is wound care, using wound backs, and debriding wounds, and different things for the patients that are inpatients. The rehab side of it goes on too, but you're not as big a part of that because you're not rehab. Even though it's medicine and rehab, the rehab is the therapist doing it. Spinal cord is a great injury if you ever want to go into it. It's real fun. But you do a lot of wound healing. Once again, if it's an epidermal wound, if it only affects the epidermis, we're not worried. That wound, as long as you don't let it get infected, it's going to be no problem. But it's not going to scar you. So you have normal return of function. Deep wound healing is where all the fun is. Not for the patient, for the provider. Deep wound healing, we got to take this wound. And if you want to see wounds, I mean, I'm talking deep. Like people who come in a wheelchair that have your ischial tuberosities and they develop cutaneous ulcers there because they can't feel when they're sitting on them, they develop wounds down there. I have people come in with wounds so big, basically on their butt, right, that we couldn't figure out what was leaking out of this wound and we couldn't get it to heal one time, and it had formed a fistula with the bladder. And what was leaking out was urine into that wound. Well, that would never heal. And so I would see a lot of that kind of wound. So I'm telling you that because some people are going, yeah, I don't want to deal with that. And some people are like, never even thought of that. That sounds pretty cool. And how did you find, they're like, well, how did you find the fistula? Yeah, it took a lot of people. All right, deep wound healing occurs when you affect the dermis or deeper. In other words, the dermis all the way down to bone. And we can classify that, and we'll do some basic stuff of that at the end of this, but you can classify how deep it is and we'll know what. But anything that's a deep wound is generally going to scar. Okay? That scar can be remodeled over years and disappear, but you're going to have a scar. So let's just look. I got one slide on epidermal wound healing because we can understand that one. We're going to have one key word here that we may not have thought about before. Is we know that there's basal cells down here at the basal layer, stratum basal. They're going through mitosis. So if we damage this area, we know that we can produce new cells. What's going to happen is the basal cells on each side of that open wound are going to break contact with the other ones. In other words, this one's going to break contact with these, and it's going to start to migrate towards the center until they reach each other. When they reach cell to cell and close off that wound, that's called contact inhibition. So the first thing I'm going to do is try to move those basal cells along that basal layer really quickly. Contact inhibition, that will cause rapid mitosis to fill in those cells until you get to where you no longer have a wound. That's how your wound is healed. And no scarring, minimal scab, that kind of thing. If you get into deep wound healing, we got to go through 4 different phases. So a deep wound, the first phase is going to be the inflammatory phase. Now go back to micro with Major Holsberg. Y'all started talking about the inflammatory phase yet or anything? Okay. A little bit. So, or is it on this next exam maybe? As part of the inflammatory response, we need to bring macrophages, all sorts of immune cells into this area. Most of your connective tissues are where your immune cells lie. And so when you have a wound, all of that area is going to become engorged. That's the inflammatory phase. Blood flow is going to be increased and the vessels become more permeable. We want to let all those white blood cells get out into those infected tissues or that damaged area to keep things from infecting them. That's why during the inflammatory phase is where the white blood cells and other mesenchymal cells, remember all connective tissue cells arise from mesenchymal. So are we going to have to replace some connective tissue cells we just damaged? Yes. Are we going to prevent infection? Yes. So we need white blood cells, macrophages and things to get to that area quickly. All of that happens in the inflammatory phase. Now we're going to rush in there. Along with your clotting cascade that's going to start, but we're not getting into that yet. And then the next phase is going to be the migratory phase. The migratory phase is where those same epithelial cells are going to try to bridge off and close off that wound. So they're going to try to come underneath and close off that wound so we can start some type of healing. But the fibroblasts that are in this area, that produce the fibers inside of cells are going to produce collagen fibers. So they're going to start to fill all of this area with a bunch of collagen. That's why you scar white, and why it's not a great way to heal. You have a bunch of collagen instead of those regular skin cells that get in there. And then you'll have a proliferative phase where you will complete regenerating epithelial cells underneath that. But you have to note that this area underneath this wound now has an increased amount of collagen. Think of any wounds you have. You have scars, I know you do. And if you have a big cut on your arm and it scars white, and a year later, that's there. The epithelial cells are there, but they have a lot more collagen mixed in with them, so they look like a scar. That's also why some scars disappear over time. They can remodel. Okay? It takes like a year or more, but they can remodel that area. So we'll increase the amount of collagen down below, fill this in solid to make up your dermis because it's connective tissue. Right? And then we'll start to organize and get that cells all back together, and your blood vessels will reform. Right? Larger blood vessels are in the subcutaneous, but in your dermis you do have blood vessels. So they'll reform. And that's the maturation phase, and at that point the scab's going to fall off. That's a basis of deep wound healing. Keeping in mind that if you have a wound, like if you have somebody in a nursing home that has a pressure wound, and we heal that, we put a wound back on that. If you don't know what a wound back is, it sucks negative pressure on a wound and causes granulation tissue for it. If you learn how to do wound backs, you make some big money out of it. Shows how hard you want to work. But they put pressure on it. And so we get that wound to heal. It looks perfect. It has a scar, but it's perfect. But that scar tissue is never as good as it once was. And so they generally, once you get your first, let's just use a regular nursing home patient. Nursing home allows them to lay around, they get a pressure wound on their butt. That tends to recur because the scar tissue is never as bad. And in spinal cord, the rule is you can spend $10,000 a day doing wound care with different products, but there's a golden rule to wound care. And then I'll stop talking about my favorite stuff. You can put anything you want on the wound and it will heal, except the patient. That's what caused the wound, that's what's going to cause it again. I would use injections that cost like thousands of dollars, and we would do it every day for weeks into this wound. But all we're doing is speeding things up to get them out of the hospital and stuff. It doesn't make it heal any better. Now tell that to the what do you call them? When people come to the hospital and try to sell you stuff? Vendors. They're vendors, but there's a name.
Reps.
Drug reps, product reps, oh my goodness. They don't even bring lunch anymore, so I stopped seeing it. All right, burns, last part here of this. We'll finish out with burns today. We're going to study burns on the EMT type level. We're going to study burns in emergency medicine on a PA level. We got to start somewhere though. I'm saying that for people who've studied burns before. We're going to go through the basic way to classify burns. Right? There are actually, when you look at burns and you say, well, first degree, second degree, third degree, we could actually increase how many different ways that we describe these burns. Let's just say that. But for now, we're going to leave it at this. So it doesn't matter how it was burned, whether it was burned in a fire, you had chemicals that burned it, a lighter, whatever that might be, and we'll say first degree, second degree, third degree. Really, I couldn't do it completely, say first degree without saying, yeah, but the real term for that right now is it's a superficial burn, which is easy to understand. That means you've only affected the epidermis. So we can stop there because I don't have to read the rest of the side. If it only affects the epidermis, we already know it's going to heal just fine. Okay? And we've had a sunburn before. Redness, itching as it starts to heal. So if you have blisters on that, it's not considered first degree. If you have blisters on that, you've gone to second degree or what's called partial thickness. Right? So a partial thickness burn has destroyed the epidermis and possibly different layers of the dermis. mean partial thickness means we've gone through the epidermis, and now whatever degree it is, we're down into the dermis. We haven't gone through the dermis yet, but we're down into that dermis, right? So it tells us that we're going to lose some skin functions. However deep it burns in the dermis, we're going to lose those skin functions in that area. We're going to get redness, pain, blisters, swelling. Depending on where you're at in the dermis, you could lose things like hair follicles, sebaceous glands, sweat glands. Let me rephrase it. Once again, it depends on how deep. A lot of structures, like your hair follicles, your sebaceous glands, remember they're associated with it, they're deeper in the dermis. And that's why I said that unclear a second ago. That's why when I say it's epidermis, but you're just down into the dermis. So I think of it more like being in that superficial portion of the dermis, right? Or that papillary region where you're above the hair follicles. That's a partial thickness. And you may or may not scar, depending on how bad that wound is. Full thickness is where we really, when you study burns and treat them, you got to classify it even more. Right? But for us, a full thickness burn is basically, just think of it going down to the bone. It's burned through the epidermis, the dermis. We've killed off all the hair cells, all the nerve fibers. It's generally not going to be any pain in that area. Now the surrounding tissues are going to swell and become inflamed. They're going to start to hurt. But that particular area, like you could debride this area and they're not really feeling it, right? Because they don't have any pain fibers there. If it's large enough, you may have to graft that area. Yeah, you're burning down to the bone or something. There's nothing there to grow up. You may have to graft and cover that area so it will burn. If you ever go over to AMC, right? They have a burn unit. It's worth it. If you ever get the chance, go through and ask to follow somebody around for half a day in the burn unit. You won't want to go back. I got to work there for 6 weeks once as a physical therapy assistant. I didn't have hot one. Every room's like 85 degrees and you're fully geared down. But you'll get to see a lot of interesting burns. The downside is you'll get to see a lot of people that destroy your faith in humanity because someone did the burn to them, that kind of thing. I don't like that side of it. Okay, epidermis, that's your skin, or your sunburn. That's the first degree. Like I said, we're keeping it pretty basic. If it's going down into the dermis, I know it shows the whole dermis there. Going down kind of into the dermis, and it already destroyed the epidermis, that's a second degree burn. And you see the blister. And then a third degree burn, we're just going to say everything's burned. Right? And I have my last story for the day here. This is not a digression, this is an actual story. That burn to me right there looks just like what happened. And I tell this story every time, and I tell this, and I make myself look lazy and dumb, and I make the Navy corpsman that was with me look lazy and dumb. And I tell this story so that every PA that gets out there doesn't do this. Right? So I'm in Afghanistan. I'm on 5 convoys. There's only like 16 of us. 4 trucks, 16 people. But we have about 60 locals coming on to work every day. And so they're on there. Well, there's people who will go around and clean certain things and cook and do this. They were building this place up. They wanted to put, apparently the government wanted to put a bunch of money in it so they could just turn it over to the Afghans a month later. But that's sarcasm from what I left. But the medic came to me one day at the corner, a little hip hop kid, loved him, and he said, "Hey sir, I just want to let you know the kid who's sweeping like the officer concrete floor over there, he does that every day. He came to me and had a burn on his hand." I said, and I was doing something else. I said, "Oh, he burned his hand." I said, "What'd you do it for?" He said, "It wasn't bad." He goes, "I just put some Sylvania on it, wrapped it up for him. I just want to let you know I did that." Because you're not supposed to treat locals. So I said, "Okay." Never thought about it again. We need to ask more questions, right? I need to ask questions. Even though it's a local kid, be careful. And a week later, I see this kid, and I go and I said, and I never let him clean my room. I don't trust him. So I lived in this little metal building. I make it sound like it's great. We have little individual rooms compared to the wood huts. And he would come in there and everybody let him sweep out the room. I'm like, no, this is a no barrier room. Not in here. Because I want to leave Afghanistan alive. Nothing against him. I had to tell that too. But I saw him and I said, let me see your hand. He doesn't speak English, but I could unwrap it. It was filthy. Dressing is just brown. It was white. I take it off, and as soon as I look at his hand, I uttered the exact words that he didn't understand. Oh shit. Oh shit. And I'm thinking it faster than I'm saying it. You know those moments? Oh shit. Because I can see every tendon in his hand. And he's scarred like that. He's still sweeping. That's what I noticed it. Is he's down, I mean, he's kind of like this. I don't know. So I went and got an interpreter. I said, ask him what I should have asked the medic, and the medic said, how did he burn his hand? I already knew. How did he burn his hand? And of course, he had gone home. They run a lot of generators. He had grabbed the generator. It was an electrical burn. Electrical burn, it's going to look great. Redness, they'll burn. Oh, they burned your hand? You don't ask them what? All that skin underneath there died instantly. It's going to necrose and scar down. So his tendons were scarred down. Just to finish the story for the sake of time, because everybody worries about the kid, he got lucky. There was like a German plastic surgeon at the German hospital a mile down the road that was doing like a short rotation in Afghanistan. I guess, like a sergeant major looking to get his patch and move on or something. I don't know. He was there. And I called over there and they agreed to see this guy. And they did 2 surgeries on his hand and he was functioning great. And to the day I left, he would try and clean my room. You think I let him? Well, here today. Okay, I'm being a little facetious with all that. Ask them how they burnt their hand. Even if you're in Afghanistan, because he's a person like anybody else. But we got him fixed. Rule of 9s. I don't know why. Rule of 9s that a lot of people have studied. Is anybody here that hasn't ever seen the rule of 9s? I'm going to go over them anyway. But most people have. They took basic anatomy. Your book throws something in here that points to what we often think. If you want to estimate your body surface area burned, you can use rule of 9. In an ER, you're probably not going to use the rule of 9s. They're much better. And I don't want to get too long-winded about this, but you want to know how much surface area is burned, because you're going to have to do fluid resuscitation. They're going to lose a lot of fluids. But there are a lot of calculations you got to learn to do that correctly, or you can overload them, kill them, basically, if they're significantly burned. So this is not the way that you do for fluid resuscitation. Could you use it in a pinch in the middle of nowhere? Certainly. You want to estimate how much is burned so you can start replacing fluids. Right? But just think of it as you're just getting a question on an estimate of how much is burned. Right? So if you used your hand on any given individual, that's about 1% of your body surface is burned. It's not exact. None of this is exact. But the rule of 9s is this. That you're looking at an adult first. An adult, the head is 9. Whole head. When you look at each upper extremity is 9. Front and back is 9. Now, they did it for the sake of the picture that I didn't put the back one. There's this whole torso area is 18. The back of the torso is also 18. That makes sense? They just put them both on the front. Actually, the picture to the left of that shows that, right? And then each lower extremity in an adult is 18, and then the perineum is 1. I think they should have given it a higher number, but that's all they gave it. So basically you have 9, 9, 9, 2 9s, 2 9s. It's all the rule of 9. The Pranry actually asked me this a couple of semesters ago, and it validated that we teach this, is you're still estimating. So let's just throw it out there before you even cover it. This whole extremity is 9, right? What if I said you just burned the anterior, you have a burn of the anterior portion of your upper extremity? 4.5. Now, even in the Pantry question, when they say that and they burn the anterior of their upright upper extremity. Right? A lot of minds think, okay, well, did they burn just down here? Did they burn just up here? No, the points always that they're making is, anytime they say they have burns to the anterior surface of their torso, you include it all. Or you're gonna do that when you're looking at a product. But you're gonna just say, okay, on a textbook, that's 18. Don't think about, well, how much of it? No. Once they say that area, they do it. But if they throw in anterior, posterior, even if I do, if you throw in anterior or posterior, you're only gonna take half. Okay? Versus like, a person took their arm and dipped it in a hot tub up to their elbow and had, full circumferential burns to their right upper extremity, anterior, posterior side. Right? That's still just going to be 9. That's your whole extremity. Make sense? No? It didn't look like it makes sense. It didn't look like a question what I said. Right. If you look at a child, the last thing we got to cover, if you look at a child, children are smaller. If you ever watched a toddler, what do once they get their head going? Right? Their head's much larger and they're just going to keep moving. Okay, that's one reason. Toddlers' heads are larger in comparison to their body size than adults. But also, airways are immature in children versus adults. Any burns to the face, head, and neck area, you're at a danger for inflaming your airways and needing to be intubated to stay alive for a while, right? When a child, that's even worse because they have an immature airway. So for those facts, they gave them 2 9s for their heads. So now they have 18 instead of 9. Okay, to simplify this, tell me if it doesn't work for you. I did this in my mind. Rather than memorize the child chart 2, it's still the rule of 9s. But now we have 9 extra for the head. Where did that come from, right? Well, they're shorter statute, and basically they took it from the legs. The number, where's my math people at? This is not going to work out mathematically. It's just not, but it's going to be true. So we needed 9 more because their head's a little larger, so we're going to take it from the legs. So the legs in an infant or child there is 14 and 14 instead of 18 and 18 like adult. So we took 8 from the legs and put it up there. That's why I said it doesn't work out mathematically, but it keeps you from having to learn a whole nother picture, right? Just take it from the legs. So the only real difference in a child, 14, 14, the head is 18 instead of that. Makes it a little easier for me to remember. I don't know about you. Okay. And then you'll learn how to really classify birds later. Alright. I put a lot of definitions here for you. And one last polling question is, identify the nail root. I'm a little more dedicated on my test to making sure the line's going to exact. If you're looking at a picture on my test, I have agonized over making sure it's pointing to the exact spot. You never have to ask me, are you pointing to this? Because I'm just going to go, yeah, because I spend a lot of time doing that. And I always ask Walter, since he reviews my test, make sure my arrows or lines is where they're supposed to be. This is a little too off to me. I mean, it's a little ambiguous here, but the nail matrix is behind. So C is the nail root, the matrix is behind it. B, let's not circle. B is the lunula, E is the body of the nail, and then A there would be the free edge. Okay. I have to blow that picture up a little bit more if I wanted to use it. So tomorrow we start covering skeletal tissue, which means cartilage and bone, and how it's formed, if you want to look at any of that ahead of time. It may or may not help you if you have time. It sometimes helps to look at, well, how do we, like lineages, because that's what people don't understand. Where did these cells come from, and what are they developing into? You can tell them where cartilage is found, but we're going to look at how we make it down at the cellular level. So if they want to cruise through it, just get a heads up on it. But if not, they'll be fine anyway, because I'll teach you really well tomorrow. Maybe with less digression. I get complaints about my digression, but it hasn't stopped me yet. Because anatomy can be really boring. So for those of you who don't like them, remember, I could be like Bueller. Everybody knows that anymore, do they? Alright, y'all have a great day, I'll see you in the morning.
Win, bang, style.